I'd now like to invite Dr. George Chang to the podium. George is Associate Professor of Surgery at MD Anderson, just down the road in Houston, and I gather he broke several speed limits on his way here.
Thank you very much. I'd like to thank the program committee and Dr. Marks and Dr. Young-Fadok and for the opportunity to speak to you today, and all of you for being here in the audience. And if you know where the speed traps are, you could be pretty safe getting over here. And as I'm told, April 15th or the 15th of the month, there's a quota, so you can't speed too much around that time either. The talk I was asked to give is how do I get started? And at the risk of sounding almost schizophrenic with Dr. Wexner's talk, which was terrific that he just gave, I would submit to you that actually it is entirely consistent with the concepts that he has raised, and I hope that by the end we'll have an opportunity to think about how all of the concepts that have been presented today are applicable as we think about, as individuals may be thinking about starting out on this technique. So Lord Monahan said, the cleaner and gentler the act of operation, the less pain the patient suffers, the smoother and quicker the convalescence, the more exquisite his healed wound, and the happier his memory of the whole incident. For those of you who are here in the audience, probably this is this kind of sentiment goes without saying, otherwise you probably wouldn't be here. The history of laparoscopic colectomy was first considered in 1990, and it was first reported for cancer in 1992, but I think you've heard in the previous talks how long it has taken, really up to 2004, until it's become accepted for general application in colon cancer. And so I think it's relevant to think about this history because one of the things that we learned was there was a need for technical skills development. This became very quickly evident, and I think if we just think back to the results of some of the earlier studies in cancer where there was high rates of port site recurrence and wound recurrences, this is a clear message to us that we have to be very careful with how we adopt new technologies. The other issue with laparoscopic colectomy is that it's a procedure in evolution, and the technique for performing the operation, whether we go lateral to medial or medial to lateral, whether it's hand-assisted, whether we're using the robot, whether we're performing single incision surgery. So for those individuals who have not yet begun performing the technique, it's sort of a moving target. And so where do you jump in? I think that becomes a question that one must answer for themselves. And we've seen some of this data. We've seen that colectomy has been much slower than some of the other operations, such as cholecystectomy or laparoscopic Nissen fundoplication. Again, probably reflecting the challenges associated with a very technical operation in which the indication is often oncologic, which adds another layer of complexity. I'll skip through that because we've heard a lot about how the training is still catching up, So if we think about, we've certainly heard a lot of arguments as to why it's beneficial to offer laparoscopic colectomy, and so why aren't we offering it? Or we've certainly seen the data from around the country with the exception of Korea. It still is not being offered. Well, a lot of surgeons have felt that it's just too hard or that it takes too long, and that's fewer billable opportunities during a given day if it's taking longer. I can't spare the time to learn, or it's too expensive, that the equipment that's utilized is too costly. The operation, it is hard. It's technically challenging. It is advanced laparoscopic skill with two-handed choreography. It's operating using a two-dimensional image of a three-dimensional field. It's multiple quadrants with a large working volume without target organ fixation. The exposure is difficult. Sometimes the angles are reversed. The anatomy may be unfamiliar, particularly if we are accustomed to doing the operation one way and we adopt the steps, for example, lateral to medial versus medial to lateral dissection of the colon, particularly for proximal vascular ligation, and the operative times are longer. I think in response to that, I would say that one has to be patient and one has to not be afraid to convert if they're to get started, because the most important thing at the end of the day is that the correct operation is done and that it's appropriate for the patient and that it's safe. And if we just think about conversion to open surgery, some of this data we've seen, but here's the data from the classic trial based on the year of accrual beginning 1996 and completing in 2002. And we can see in the pink is the not converted, and in the blue is the converted. And you can see the proportion of patients who are converted is about 20%. And it was much higher earlier on, but even into 5 years, there was still a significant rate of conversion. And if we look at the conversion rates in the COST trial, 20%, in the COLOR trial, 17 or so percent, and then in a observational study cohort, the laparoscopic colorectal surgery study group, which are interested surgeons, the rate was significantly lower, but still in experienced hands, there's a rate of conversion. So it is acceptable for there to be conversion. I think that one has to recognize that if they're getting ready to start. So, in response to these why not questions, it's too hard, well, it does get easier. It takes too long, well, it does get faster with time. It will always take, it may always take longer than open surgery. I can't spare the time to learn, but one really can't afford not to learn if they're going to do it, and once you've learned, it becomes much easier. If it's too expensive to do the procedure, the shorter hospital length of stay certainly can reduce the inpatient costs. So how do you get from not doing this operation when you need to get the expertise and the skills to be able to perform the operation effectively? So I may break this down into a number of steps, and I think, again, we're going to echo some of the comments that we've heard earlier. I think, first and foremost, one has to understand their skills and limitations. What is the minimally invasive composition of your current practice? Are you a high-volume, minimally invasive surgeon, low-volume colon surgeon, or are you a high-volume colorectal surgeon with a low volume of minimally invasive practice? I think you have to figure out who you are. Do I need to learn basic laparoscopic skills, things like establishment of a pneumoperitoneum, trocar placement, and so forth? Do I have advanced laparoscopic skills, how to use energy devices safely? Am I ambidextrous? Can I work in reverse angles? Do I have sufficient clinical volume to ascend the learning curve for laparoscopic colorectal surgery? If you're not performing very much, if the colorectal surgery is not a major part of your practice, then perhaps the laparoscopic route may not be the best for you, because the amount of effort or amount of time that will take to ascend the learning curve may be quite long. And do I need to brush up on my colonic anatomy and understand the principles of oncologic surgery for cancer indications? I think this is a very important question for all of us. We can certainly seek out appropriate training, and there are some guidelines, including one published by the American Society of Colon and Rectal Surgeons and the Society and SAGES, providing some guidelines as to how the training should occur. And there are other ways to seek out appropriate training. There are interested society meetings and symposia, including the ASCRS. There are video presentations at the nuts and bolts session. SAGES has video presentations. There are hands-on courses. There are multimedia journal publications, both in the diseases of the colon and rectum and surgical endoscopy. And there are online video repositories. WebSurge is one. It's free access. And I think it's essential that unless one has access to partners or other experiences where one can observe these operations being performed, one must go to some repository of these procedures to see how it is done. And of course, there's SAGES TV, and there's a repository of videos there as well. And so this is another important mechanism for getting the appropriate training. There are other training options, master classes and symposia. There are colorectal fellowships. I don't know how many people who are in their practice are going to go back to a colorectal fellowship. There are preceptorship models. And there's mentoring and pairing with an experienced partner. So one has to figure out who you are. It may be you and a skilled laparoscopic colorectal surgeon. It may be that you are a skilled laparoscopic surgeon and you need a skilled open colorectal surgeon that you will partner together with, and then you can ascend the learning curve together. Or a skilled open colorectal surgeon, maybe that's you, and a skilled laparoscopic surgeon will allow you to ascend the learning curve together as well. I think this is very important. I have 8 and an 11-year-old, and we always talk about the commitment to learning. I feel like we do homework until late at night every day, and I wonder, I never did that kind of homework when I was younger, but I feel like I've recommitted to doing the elementary school homework. But I think we have to be prepared to make a commitment to learning, and don't expect the results to be overnight. the risk for conversion, if we were to look at it as one marker of learning, it certainly improves over time. And this is some data, this is old data from the Cleveland Clinic, where we see that even after 175 cases, there are still improvements in conversion. And so this is a long process. I think it would be inappropriate to, or you would be misleading yourself to think that you ought to be able to ascend that learning curve by tomorrow or next month or even perhaps next year. Another important component of any new technology or bringing any new component into your practice is to be prepared. And to be prepared by familiarizing oneself with the equipment and the instruments, understanding what are the essential pieces of the puzzle, including 30-degree or flexible laparoscopes, the type of instrumentation. If you do not have a high volume of laparoscopy in your practice, it can be daunting to find yourself in the middle of a room that kind of looks like this, so one has to be familiar. SAGES has a very nice card that is published regarding troubleshooting in the operating room, and so those are the kinds of resources one should be familiar with. And once the equipment is familiar, then one has to be familiar with the patient. And I think it's very important to go through the preoperative considerations, including if it's a tumor, localization. One should consider repeating the endoscopic procedure his or herself to confirm the location, mark the spot with tattoo, make sure that all the appropriate workup is done, like a serum CEA and radiographic studies for staging purposes. Just because this is a different technique doesn't mean that we can forget all the oncologic principles that are appropriate for a given patient with colon cancer, as an example. And I think another part of preparation is anticipating the challenges, and the challenges are going to be the need to work in multiple quadrants. Gravity can help to alleviate that. There's proximal vascular division, so one has to be precise in their operative technique. One cannot hurry these steps. The flexure mobilization requires team coordination and coordination with the anesthesiologist, perhaps, for positioning of the table, as an example. One should be prepared and be thinking about pre-existing inflammation or adhesions to know where the operation might be challenging, and also that if the lesion was poorly localized preoperatively, then one has to be prepared to deal with that. I borrow a comment that I learned from a good friend of mine in medical school. One can substitute anything for surgeon. I try to teach that to my kids as well, but a prepared surgeon is never conquered, and one can be prepared to succeed, and sometimes to succeed one has to stop and consider an alternative technique such as open surgery. So are you ready to get started? You've done all of these things. All colectomy procedures may be performed by a combination of 3 to 6 ports. They can be 5 to 12 millimeters, and I think the principle of triangulation, this is a very basic principle, and one should be flexible. But these 6 ports will get you pretty much any operation for the colon, whether it be on the right, working from the left, or whether it be on the left, working from the right, or whether it be in the pelvis, working from perhaps all 6 or 5 ports. Another part of being prepared is appropriately selecting patients, and we all have encountered this problem. And this is a real patient of mine. This patient happened to undergo robotic proctectomy, but one can get a lot of information from all the studies that we obtained. This is a tumor within a 6-centimeter wide pelvis in a pretty huge guy. And so these are probably not good patients for the first case. And so it certainly is helpful and worthwhile to be patient and identify the right kind of patient. And if we all lived in Korea, we would all be very happy because we could operate on patients such as that. There is a spectrum of difficulty, and this is one should select patients and one should select the operation. And the operations go from easy, sort of the procedures that are listed there, to become familiar with the techniques and the instrumentation, to ones that are quite difficult. And these should not be the first operations that are performed, certainly. And if you don't progress, there's always the solution, which is to open. But I think, as we've heard from some of the earlier speakers, once we've done all of these things, we're not done, because it's still important to critically monitor and track our own results. Ideally to publish the results and make them publicly available, but certainly to be honest with yourselves and to monitor your results. It is a difficult procedure. This is an older statement, but This is from the laparoscopic colorectal surgery study group in Europe, and this was the comment that was made at the time. Laparoscopic colorectal surgery is very demanding. It can be performed with low morbidity and mortality rates only by a surgeon with above average experience with this type of surgery and a large case load of laparoscopic colorectal procedures. We've probably learned a lot more since then, but some of the principles of these comments still apply, and I think it gets back to some of my earlier comments about thinking about your own practice and where you fit for all of these things. But at the end of the day, I think the important thing is to be patient, to monitor your results. But if you do not have the volume, it's okay to perform open surgery. This is another way to think about it. I think that when we monitor our own results, it's not helpful to monitor our results and then have nothing upon which to compare, and no more precision than the U.S. Geological Service. But one has to compare to benchmarks, and there are some guidelines as to where our practices ought to be, and I think these are simply they're exactly that. They're guidelines because they may not be applicable to each one of us. And many of us might even say that the numbers that are presented by the guidelines are too small. So it's very important, I think, for us to consider all of these factors as we get started. So just a plug for continuing to monitor your results. These are 1,000 laparoscopic colorectal procedures performed by one surgeon. And in this cumulative sum analysis, looking at complications and recurrences, you can see that even at 1,000 cases, the curves have not leveled off. The learning continues, and that is why it's important that we continue to monitor what we do. So to summarize, laparoscopic colectomy is an advanced procedure that can be mastered. But I think it's important to understand our skills and limitations, to seek out additional training, commit to learning. I certainly feel like I'm still learning all the time. To be prepared and to monitor our results, and then remember that conversion is not a failure, it's good judgment. I think Peter Marcella likes to say that all the time, so I have to credit him for that. But no one will remember the good outcomes achieved by conversion, but the bad outcome from poor judgment will be remembered forever. Thank you very much for your attention.